लिख देना
urea is 140.
भेदभाव कदर
So, if you look at mortality, at day 28, 45% died if they were waiting. 30 in the group of more delayed. At 2 months, 55% died
the condition where renal
in the group of more delayed dialysis study.
already
So it looked like that.
already
If you
there is
keep on
already
waiting,
presentation
you
and
might lose
going on.
patience.
So
So waiting
please
too much,
attend
waiting
it,
too long can be harmful.
give attention there.
So what do we do with this
When
gentleman
already
now?
presentation is going on, then how can
So what do we do?
condition then.
Now we stage him. We have stage. Because if we look at these, the
Stage.
summary of these trials,
we have stage?
you see that stage 3 AKI is one of the criteria in randomizing patients.
For dialysis.
But doing early doesn't do any harm, any benefit in medical issue. We don't know about the post cardiac surgery patients because they did better.
Huh?
So now for this patient we will do a KT staging.
Pulmo.
So serum creatinine more than 3 times the
No,
baseline
you'll be
or an
professor.
absolute increase to more than 4. So urine output
Guys.
criteria,
You know him.
urine output drops to
Dr. Pulmo.
less than 0.3 ml per kg. So this is the
You
criteria.
want to say
Now this
something?
patient
My
is
viewers.
2.8.
No.
Thank you for your video.
So
जो
0.4
एक डाल
ml
ऑनलाइन
urine
शो
output
टाइप
criteria. So from the urine output criteria it is stage 2. From the creatinine criteria maybe it is stage 3.
लाइव में डॉलर या लाइव ले जाओ.
So this patient has severe AKI, oliguria, rising creatinine, but it doesn't have a refractory hypertension.
Till date he has
Doesn't
got
have
only
other
$1
indication for that.
and
ये डॉलर पहुंचे वाला नहीं है मतलब जो डॉलर
Therefore, if we randomize this patient to one of the groups of the key trial,
0.6 to 1.2
watchful waiting strategy will
लैब वैल्यू वाला
be
भी
reasonable
नहीं
rather than
थर्ड
doing an
क्रिएटिनिन
immediate
हेरे त खासमा डायलिसिस पनि गर्न हैन
If
क्रिएटिनिन
we
हेरे त
apply this patient to AKT2 trial, we don't want to further delay. So we'll wait and we don't take the patient to more delayed or wait until the urea is 140 milligrams.
हेर बाबु त्यहाँ 8 जना छ लाइभ
So if we apply Elaine trial criteria, which may not be made by this patient because this is not a cardiac surgery patient.
16 जना
Because 80% of the patients in the Elaine trial were cardiac surgery patients. So Elaine trial may not be applicable to this gentleman. If we apply the
We are
ideal
on
ICU
screen.
trial criteria, there is no difference in 90-day mortality whether you dialyze him right now or wait for
We
1
are
or
on
2
the
days
screen.
or wait until emergency
Yes,
indication
same
for
as
dialysis.
Eh,
So the same thing. So if we apply the start AKI criteria, if we randomize this patient to one of the groups of the start AKI trial, doing accelerated approach or doing dialysis within 12 hours increases the risk of persistent dialysis dependence at night. So if we dialyze right now,
हामी
it is
हेरिसक्यौँ
more likely that this gentleman will be dialysis dependent at night. Dialyzing him early could potentially stun his recovering kidneys and leave him bound to dialysis. So possible outcomes for this case is if we do our early strategy in 90 days, no improvement or no survival benefit, needing renal replacement therapy. If you start, it is 100% that you will get a renal replacement therapy. But if you wait, 50% chances that he will recover and dialysis not required. So if we do an accelerated strategy, there is high risk that he will be dialysis dependent, and adverse events will be high if we follow the accelerated strategy. So compared to delayed strategy, more delayed strategy is harmful. For this patient, we will not initiate immediate dialysis. Rather, we will wait. We will wait and monitor this patient. Continue intensive medical management We will monitor strictly for progression of renal dysfunction, and we will start renal replacement therapy only if absolute indication develops. Reassess daily for spontaneous recovery. So when should we start dialysis in this patient? So when there is a severe acidosis, when there is development of severe hyperkalemia, when there is pulmonary edema, when there is oliguria or anuria, or there are other uremic complications that mandate starting renal replacement. So when we approach, how do we approach detecting renal function in the ICU? If there is severe AKI and no complications, we observe early evolving shock, and we feel that the patient is recovering from various parameters, clinical and biochemical parameters. We will wait.
Got it.
There is rising urea, or there is
Got it.
increasing metabolic burden because of creatinine rising, say, over 4, and we wait. We will start thinking towards renal replacement. If there is oliguria or worsening kidney function, then we will consider starting RRT. If there is anuria, we will consider starting RRT. If there is fluid overload and oxygenation is hampered, then we will start RRT. If there are other emergency indications, other emergency complications like bleeding, we will start. With hyperkalemia, acidosis, we will start. There are many other extracorporeal therapies that are being investigated. Interested members of the audience can even research on this. So in the last 15 seconds, the clinical takeaways for the ICU team is, if there are no life-threatening complications, a delayed strategy would be preferred.
Satish.
Identify the indicators for urgent dialysis
फोटो खींच
and
दो
avoid rushing to renal replacement therapy and wait until there is some issue or until there is, and we don't
प्राय जसो
keep on
इथानल
waiting
टक्सिसिटीमा
for,
गरिरहेको हुन्छ के
delayed or
एलआइसिस
more
हैन
delayed period, say
धेरै
more
केसहरू
than
आउँछ
4 days or 5 days of
What is the
developing
antidote
stage 2
of
or 3.
ethanol poisoning?
मिथानोल
Take it.
इथानोल
So with
पोइजनिङ
this,
नै हुँदैन नि
I thank you for your patient hearing,
What is
and
treatment
I
of
thank the
ethanol
organizers for
poisoning?
this
Tell us
20 minutes.
listen to question. Yes.
ए इथानोल
What is antidote
Thank
of
you,
ethanol
Dr.
poisoning?
Mandal.
That is
Actually,
antidote.
I am not a clinical nephrologist, but as a
Homepage
intensivist,
role.
what I can
Homepage
renal
role.
conclude
renal replacement
Yes,
therapy
they were renal
says
त्यही
अब
त
चलाउन त धेरै चाहिँ
till
चलाएको
now
छ।
the beauty part of renal replacement therapy is we have the evidences very clear. All those 5
अहिले
trials
यो
that
डिस्टर्ब
have
गरिदियो कि मेरो
clearly
लाइफमा
they have put
7
the
जना थियो।
information. The only thing is like Iliad trial